Hi, everybody. We are excited that you're here. I'm Michael Munson with Forge, and I'm going to start over with that because Derek is now ready to interpret. So, hi, everybody. We're going to get rolling. I'm Michael Munson with Forge, and we're really excited to have this first part of a three-part series with Annie Lakatosh. Did I get it right this time?
Perfect.
Excellent. I've been practicing. So tonight is on feminizing hormones. The next one will be on masculinizing hormones. And then a month later will be non-binary folks and how to use hormones to affirm identity if folks are interested in doing that. So we are excited to have roughly an hour. If we go over, we go over. It's your call, Annie, how long we last. Let me do some housekeeping, a little bit of housekeeping. So as folks can hopefully see, we have an ASL interpreter. We have not been able to get our captions to work in webinar format, so I'm sorry that there is a little bit of lack of access there. Your Wisconsin endowment. So we're really grateful for their funding, and we're really grateful for the partnership that has been there for a while, but is now kind of formalized through this programming. So I'm going to not waste any more time, and I'm going to turn things over to Annie, who's going to talk all about feminizing hormones and wherever else you take us tonight.
Excellent.
So thanks.
No, thank you. I'm thrilled to be a part of tonight's conversation. I think that this is a really great opportunity for me to share what I know about feminizing hormone therapy, but also I have the joy and privilege of starting people on HRT as well as continuing and maintaining that over years. So that's it's really a great process. I do want to just caveat that I am not an endocrinologist nor a gynecologist, and we do in the Inclusion Health Clinic have both of those roles for anyone who has very specific needs. And if anyone does have any questions, I can certainly help field those tonight as well. So just to get started, this is what we're going to cover tonight. So we're going to review the current standards of care. And I would say our conversation tonight is probably different than it would have been 10 years ago, 15 years ago. And it may be different than what it might be in 10 or 15 years in the future. But it's very exciting that we have standards of care. We're going to talk about how to get started on feminizing hormone, and then what to expect. What are those appointments? What do they consist of? And what can you anticipate will happen? And then we're going to go over the effects and risks. And I think this is really important and probably something that people have discovered on their own through the internet. And then because of my role as a primary care person, I can't help but talk about health maintenance. And that's always something to consider in HRT. So I'd like to start out with just formally saying that not all sources on the internet are equal. So I refer to Dr. Google or the Google machine sometimes as being a good resource, but it's not the only resource. So I like to share with people who I utilize, but also who the national leaders are for hormone replacement therapy. And I want to also say that these are standards of care. So this doesn't dictate a specific recipe for people. It might be very different from everyone. These are just really, it's the backbone of care. And then you should have a conversation with your prescriber about what makes best sense for you. And you're going to hear that theme throughout tonight's talk. So the national leaders that we utilize in terms of recommendations and guidelines are listed on the right side of the computer screen. So that includes Fenway Health and Callan Lord, both on the East Coast. We have the Endocrine Society, who has provided some guidelines as well for care. And then the University of California, San Francisco, or UCSF, I utilize them all the time, and we're going to get into them a little bit in greater detail, as well as the World Professional Association of Transgender Health, or WPATH. So those are the leaders that we utilize. I recognize that there are some other philosophies out there that you can access specifically on the internet. So if you find them and have questions about them, I would encourage you to talk to the prescriber of your HRT or your healthcare providers involved in your care. So starting with WPATH, we're going to kind of go up from the bottom there. WPATH outlines these 4 specific criteria for starting hormone replacement therapy. And I want to start with this just so that people can see really what we are looking for as providers and before we start hormone replacement therapy. So it's that persistent, insistent, consistent demonstration of a gender. It's also the capacity to make an informed decision. So at the Inclusion Health Clinic, and this will vary depending on your location, we see people at age 16 and above. And so that's an important consideration as well. The age of majority in any given country, again, we see people at age 16 and above. And then if there are significant medical or mental health concerns that they need to be addressed. And if people have concerns specifically about that, I want to make sure that I cover that tonight as well. So I like to caveat WPATH. These guidelines came out in 2012, and they really come from the lens of a psychiatric or psychological arena. And we're trying to change that. I know that one of our endocrinologists actually had been involved with looking at these guidelines and updating them, and that was last year. So I'm assuming that everything has been put on hold because of the COVID-19 pandemic. But it's a really great document because it provides some very specific information. And if you're ever in a clinic appointment with me, I sit there and scroll through, but these are the pages from the document that we're going to review tonight, but I also want you to be made aware of. And it really gets down to the feminizing effects of hormone replacement therapy, as well as the risks. And those are both really important concepts to consider as you start this journey. Switching over to the University of California, San Francisco Transgender Guidelines, this is really a wonderful site. It provides a lot of information, not only about hormone replacement therapy, but it also provides information for both prescribers and patients about any symptoms that they may encounter within their journey. And so I call it the backbone of HRT prescribing. Again, we're going to get into this a little bit more in just a moment, but it gives you a really nice chart, well displayed, about what the options are for example, estrogen therapy. How does that come? It's, injections and pills and patches. And there are limits to the dosing, and they help outline that for us. There's also some information about the nuances of the medications that we do prescribe. So if anyone is interested in this, you can see the website I included on this slide, because it is exceedingly accessible to all of us. And if you have any questions, this is really a wonderful resource that's backed up by research as well as clinical care. And then I utilize this site as well if there are any concerns about primary care issues. So this is where I find information about bone density, and we're going to go over that in a little while. I sometimes realize that I use terminology, or clinicians use terminology that might not be well socialized in anywhere outside of a clinic setting. And so when I talk about health maintenance, I'm talking about preventative health. And those recommendations, as you can see on the right side of your screen, it's included in this guideline. It also helps us address fertility issues. So that's a really important piece of the conversation that you should be having with your prescriber as well. And then if you do develop symptoms over time that become worrisome, or you're not quite sure what they mean in the context of your care, I encourage you to reach out to your clinician so that you can have that conversation. And the UCSF guidelines also provides some great evidence in terms of how to navigate those. And when I think about this, I think about pelvic pain can sometimes occur. Sometimes bleeding can be a concern for some people. I would say scrotal pain is something as well that we will encounter. And so this guideline gives a really great focus on what to do in those situations. So this is what it looks like when you go to the site. And on the left-hand side of your screen, you can see all the different topics that it goes over. And I'd like to just call out the name right in the middle of your screen is Maddie Deutsch, and she is a researcher, she's a physician, she's a transgender woman, and she feels very passionate about the care provided. And it's just a dynamic resource that we have. And the exciting thing too is that UCSF is really working on ongoing research to propel transgender health in general. So it's really a page to watch. And I like to bring that up again, just because our conversation may change in 10, 15 years, but this is the information that we have currently. So I want to switch gears here a little bit and ask, or just to review, how do we get started on HRT? Some of you may already be on hormone replacement therapy, and some people may be considering it and not sure how to dip your toe into the pool here. The first thing that you want to do is find a clinic or a provider, and places like Forge really are great community resources that can send you to the right place. They can, connect you with people that may be the most appropriate for you given your geographical location or your specific needs. So I really encourage everyone to utilize their community resources, friends. What were people's experiences? This is where community is so important, that we have these conversations and we hear other people's perspectives. There are two different models that you may encounter when you look at different clinics. The first one is the informed consent clinic. And so this is really where you go in and have a conversation with someone. You don't need to come in with a letter stating that you have gender dysphoria or that you should be started on HRT. That's really a conversation that's done between you and the prescriber or the provider that you're in front of. There are non-informed consent clinics out there, and those folks would encourage an initial conversation and then definitely a letter stating that you have this diagnosis of gender dysphoria to help support the process of hormone replacement therapy. And in Inclusion Health Clinic, we are an informed consent. So it really is based on a conversation that I have with patients. And we're going to go over some of those questions that I and others will ask. So that you have some idea of what to expect. But this is really where you want to share your journey with folks so that they know what your goals are and where what you're looking to do. I feel like this is kind of a joke, but kind of not. I definitely want to encourage people to come to their appointment. So I would say every week I have a no-show of a new patient. And I think that there are lots of things that contribute to that. We work really hard to be as welcoming as possible. And that getting to an appointment sometimes can be hard, really, really hard. I want everyone to hear that it's okay to be anxious and a bit nervous about it. When I see heart rates above 100, I think this is a new patient visit for sure. I want you to know too that we get nervous. I want to make sure that people feel comfortable and welcomed. And of course, I want to make sure that there's a really good, gelling and feeling in that appointment. And then I want you to think about what your expectations are of that appointment. Do you want to get started on feminizing hormone that day? Do you want to talk about it? All of those things are okay. And again, this isn't a recipe where, you have to go A to B to C to D. You really have that conversation about what your goals are with your provider. And even just to say, this is really making me nervous and I'm not sure, or I've been waiting for this for 14 years. I really want to get started as soon as possible. So those are good things to bring up. So at your first visit, these are some of the questions that I know our providers in our clinic ask. I certainly ask these as well. And so I like people to be prepared. I, for one, am someone who likes to be prepared, especially if I'm in a situation where I am a little bit more heightened in terms of my nervousness or my anxiety. But the provider is going to want to know, when was the first time that you identified as being a gender other than the one that you were assigned to at birth? That might be worded differently depending on who you're seeing, but really to start that process of considering when that journey began for you, or when you started putting those puzzle pieces together. And then how long have you been living as your gender, so that really that social expression, that community expression is important to consider as well. Sometimes I feel that the question about support from family and friends can be a double-edged sword, because a lot of us come from families that it's not a clear support, or it's been a very complicated history. But at the end of the day, what we're looking for is what is the support that is currently in your life. As people embark on feminizing hormone therapy, you're going to change. And so who's there to help support that process for you emotionally, mentally, also physically? And so that's the purpose of that question, is just really to better understand who's in your life and who are your touchstones. And then if you've ever taken HRT in the past, it's good to mention that. Not that it's, something that will preclude you or stop you from getting HRT. It's just important information, because at the end of the day, we want to make sure that you've got all the information that is necessary for your journey, and that you feel as well informed as possible. Some of the benefits of getting HRT through a clinic is it's really medically monitored. So we're looking at labs, we're talking to you about your blood pressure, we're monitoring the changes that you're experiencing, so that we can support that journey forward. When HRT is not prescribed, we can't guarantee that the product that you're taking is safe, or is even the product that it purports to be, or contends to be. So. And then if you've ever taken HRT in the past that's been prescribed, did that work for you? Do you want to stay on that same formulation? Tell us what that was like for you. So again, we can help you make good decisions about what makes most sense for you currently. And I feel like I've said this several times, but it's something that's really important. And what are your goals of care? What are you looking to accomplish? So as I had mentioned earlier, there's no recipe. And some people will come in and they see themselves at a certain point on the continuum of the feminine presentation. Some people may be on, at one point, and another person may be at a different point on that continuum. And so to be clear about where you see yourself, where you want to see yourself, and where you feel you are to be, is really an important piece of that conversation with your provider. So when I was preparing this visit, this PowerPoint, I was thinking, what is it that I want people to know from my seat? What do I feel needs to be communicated? Because I really appreciate when patients tell me things so that I can be better. But I want everyone to know there are no wrong answers in this process. So really, it's about creating a relationship where we then start looking at your healthcare and making sure that you are living really the best version of you in the best way possible, with the most appropriate tools to do that. And so again, where are you at in your journey? Some people come and they have told me that they've been waiting for 14 years to start this journey, and that's always exciting, especially when we get moving on feminizing hormone therapy. And some people have been considering the journey for shorter periods of time, and that's okay too. So in the informed consent clinic that I work at, really there's no requirement to have seen a mental health provider. So I don't know if that's something that people have come across before, but it's really to come to your appointment and have these conversations with us. So where are you at your journey? Where do you see yourself in 1 year, 5 year, 10 years? And then how can I best, or how can your provider best help you to reach those goals? And it can change over time as well. So at the beginning, you might feel that really just placing your big toe in the pool and that's enough and let's see how this goes is okay. Some people want to do it a lot more aggressively. So I think about a train like zipping out of the station, and that's okay too. Let's talk about what that might look like. I've had the experience too where if someone is looking to start feminizing hormone therapy and then something happens and then they stop, and it's okay. Tell me what's going on. Tell your provider what's going on. So again, we can help address some of those concerns or issues. I think it's also important during the appointment to talk about your expectations or what you see needs to happen over the first year, at least after starting hormone replacement therapy, but also time after that. So how frequent are you expected to have labs completed? How frequent are you expected to see your provider? Especially with the COVID-19 pandemic and all of our social distancing recommendations. I'll tell you that I think our clinic is very clear that once we start HRT, we want people to feel well supported, and we offer different types of visits, so in person and virtual for sure. But we want you to continue your journey, and that's why we help support that process to begin. I know for my practice, I like to do labs every 2 to 3 months for that first year. And that's really to allow me to watch any changes that may occur and any red flags, what we lovingly call red flags, might crop up so that we can address those while that feminizing hormone therapy gets started and gets ramped up. We also look at blood pressure, and in some circumstances, we might look at weight, and that's not necessarily the specific number, but any fluctuations of that. That can sometimes be far more important than what the number actually is. And then I want to know, what physical changes have you been experiencing? And sometimes it's nothing, and that's okay to say as well. But sometimes people will say, already I'm feeling X, Y, and Z. And in short order, we're going to actually go over those effects and the timeline that we anticipate those will happen over. So I always appreciate people coming in, so that I can see their blood pressure, I can see the whites of their eyes, and I can say, how are you feeling? How are you doing? Where are you at? And does this continue to make sense for you? Or can we increase that dose? Or how do you feel about that? So after starting hormone replacement therapy, and again, many of you may actually be on feminizing therapy at this point in time, so this might sound somewhat familiar for those of you who aren't. You will definitely experience emotional and physical changes. So it's like having a second puberty, and it's important to be aware of that and really to have people around you that can support that process. There will definitely be changes to fertility. So this is a part of the conversation that you should have with your prescriber. This doesn't mean that having biological children is completely off the table for the rest of your life. I explain it that it's just a lot more blood, sweat, tears, and money that goes into the fertility process. So for people to be aware of that as well. In some circumstances, when I talk to people about their desire to have biological children prior to starting HRT, there are some options of sperm banking and preservation options like that. I know that there are some online resources that some of my patients have utilized. Unfortunately, it can be very cost prohibitive, so that's a consideration as well. But just to be aware of that. And then HRT, feminizing hormone therapy, is not a form of contraception. For anyone who is looking not to conceive, definitely there needs to be that conversation about how to avoid that from happening. So, and that I would say is just as important as the fertility conversation. And then again, you want to talk to your prescriber about how often do they want you to come in and be seen. And I had mentioned earlier that I like to get those labs every 2 to 3 months. Those are to go alongside the appointments for that first year. And again, it's to monitor things, to make sure that everything is humming along and your body is accommodating the hormones appropriately. And I would also really encourage everyone, this takes time. So for that person who had been waiting 14 years, I wanted things to go fast and be changed, immediately. But there's nothing like the tincture of time. So time will be our friend in terms of allowing those changes to occur, for you to become, to accommodate to those changes. And that means both physically, emotionally, and mentally, because you may not see major changes, but when I see people only once in every 2 to 3 months, I can start seeing those changes. I can start hearing those changes, and allow your body to develop over that time period. Now, that might not be for every provider, so definitely you want to have that conversation with your healthcare provider. Okay, so this is really the backbone of therapy, of feminizing therapy. So estradiol currently comes in an oral or sublingual formulation. It also comes as an injection, and then it also comes as a patch. The oral tablets that are prescribed, I typically just have people put those under their tongue for up to 30 minutes. In some cases, they're dissolved by 15 minutes. And there's a few benefits to that. And it's all to really reduce the theoretical risk of introducing this estrogen into your system. The primary concern by far for people starting estrogen therapy are blood clots. And so that's something, if you have a history of blood clots, if you have other health concerns that may increase your risk of blood clots, those are all really important pieces of information that you should share with your healthcare provider. With that being said, if you developed, new chest pain, shortness of breath, calf pain, that would be a DVT. Definitely, you want to be seen emergently for that. I didn't put this in here anywhere, but I do want to just mention that for anyone who smokes and is started on estrogen, again, that's not a reason to not start estrogen, but please consider that tobacco makes your blood stickier, so it's going to increase that blood clot risk. There's not great data that supports starting someone on a low dose aspirin just to reduce that risk. That in some cases, people are prescribed aspirin. I've seen that, but the data doesn't support that as a standard of care. So just keep that in mind. If anyone wants to reduce their smoking habit, it's always a good idea. So alongside the estrogen therapy, you will see emotional and physical changes. And we're going to go into that in terms of the physical changes. But I would say that in general, a lot of my patients tell me that their emotions are a little bit more labile or quick to change. So they start viewing life a little bit differently, and that there is an emotional element that they hadn't experienced before. So something to consider. The second part of the standard of care for estrogen therapy is an androgen blocker, and that's oftentimes spironolactone. This is an oral medication. It's oftentimes used in other settings for blood pressure management. So this medication can affect your blood pressure. And then this medication is also called a potassium-sparing diuretic, which means that the medication kind of holds on to the potassium in your body. So we have to keep an eye on your potassium level. For any of you who love bananas and eat, many bananas every single day, we have to definitely be mindful of that. There are lots of potassium-rich foods out there that I hope is a part of everyone's dietary choices, but it's one of those things that we just need to keep an eye on. And that's why those labs are really important to keep looking at. Now, one thing that I didn't put on here, and I had a long conversation today, was about progesterone. So there may be questions about progesterone. It's not part of the standard of care per se. Some people will have questions about it. And currently we don't have good data that supports the use of progesterone as part of that standard of care. Anecdotally, people do report some positive breast growth. Interestingly enough, it can also increase the quality of your sleep. Again, data doesn't show either of those, but I like to introduce this to my patients because I'd rather them hear it from me, and also to open that door of conversation instead of, searching on the internet and finding that information, because I know it's out there. I prescribe it for some of my patients who want it. Typically, what I recommend is making sure that your estrogen level is at that goal range that we look for. So that's typically between 100 and 200. And then once there's enough estrogen in your body, the progesterone actually has something to work with. I talked to our endocrinologist today about her approach to progesterone, and she said actually that, again, there's no data to support it. There may be some effects of progesterone, though, in the pituitary gland that suppresses testosterone further. So that is also something to consider when you're looking at the medications that you're taking for your hormone replacement therapy. So, and if anyone has questions about that, we can certainly review that at the end here as well. So, okay. So these are some of the things that I hear from my patients. My favorite thing in the world is just hearing that big sigh of relief that this is happening, or that they're seeing what they know to be true about themselves. And that's just the congruency in that is just wonderful. I had mentioned the emotional lability, or those changes certainly occurs. Breast tenderness is something that definitely happens as the breast tissue is growing. People may have a lot more sensitivity around the nipple. If something bumps their chest, that can be very tender. It's not necessarily painful, but it can certainly be tender. So I want to reassure people that those are the expected things that I hear from my patients and know to be true about that process. Skin changes also occur. So skin typically becomes softer. It's less oily. And then some people will struggle with sexual side effects. We know that with introducing estrogen and suppressing testosterone, sexual function changes for sure. And so Viagra, those sorts of medications are indicated in some circumstances. So definitely talk to your provider about that if you have any concerns. Okay, so we're going to get into really the nitty gritty, and I apologize if this is something that you've seen before. These are really important components of starting feminizing hormone therapy. Again, the WPATH and UCSF are my resources that we're going to review. And I'd like to just bring up that when we look at labs, we absolutely look at those labs through the lens of your gender. So your feminine gender. Sometimes labs will adjust those markers for us. Sometimes they won't. And so if you have any questions about the labs that you see, sometimes labs will be highlighted in yellow, and those are usually when something is out of a normal range. Don't get too worried about that. Definitely hear from your provider if they're worried about it, or if that needs to be followed up on. I also want to mention, because I hear this from my patients, is that oftentimes people feel that the injectable form of estrogen is the more, the form that shows up, I guess, and really provides the biggest change. And I would challenge that in that injections are not for everyone. And in fact, taking injections for 6 years can be tiring, and sometimes people change after that. And you can change different formulations. So that's important to understand. In some circumstances, I'll actually start my patients on patches given their other health concerns. So again, obtaining that health history and providing those really important pieces of your health history is important. Always, 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 your preference and your goals need to be considered as you start feminizing therapy. Okay, so this is one of the charts that is located in WPATH, and I like this because this really outlines the expectations moving forward. So generally speaking, the effects that you're going to experience take time. So you can see that it may take as little as 1 month and up to 6 months to see changes. And so we also anticipate those maximum effects not to occur for a year up to 5 years. So keep that in mind as well. But just going through this chart here, we anticipate body fat redistribution. So the hips are going to take on a little bit more padding. Things are going to soften, the lines are going to soften. You can anticipate decreased muscle mass and strength. So if you are used to having or being able to have a very physical job, that's going to change for you for sure. I had mentioned this earlier, the softening of skin and definitely decreased oiliness is something that we see. So less acne in general. The next things on the list, the decreased libido, as well as this decreased spontaneous erections and sexual dysfunction. That's a change. And so people need to be aware that that is likely what they're going to see from their body. And that can be as soon as 1 month after starting feminizing therapy. We do see breast growth in the first 3 to 6 months. With a maximum effect of 2 to 3 years. Now, a lot of our surgeons, before doing augmentation of breasts, they like to have people on hormone replacement therapy for at least a year. And part of that is so that they can see the effects of just your genetics and under the influence of those hormones taking shape. And so they want to maximize just the development that we anticipate comes from estrogen. We also see decreased testicular volume as well as decreased sperm production. So it's not that the sperm goes down to zero, it's just that the production is far, far less, and there's less motility to them as well. So if you're looking to have biological children, this is the part that makes it more difficult. If you don't want to have biological children, this is the part that just changes the sperm production. There is a thinning and slow growth of your body and facial hair. So people will come in and their arm hair, their leg hair will be slightly thinner, less dense, even lighter in some circumstances. There is no anticipated regrowth of any lost hair though on the head. And so just to be aware of that as well. So those are the expected effects that I see from my patients. And then these are the risks that are outlined again by WPATH regarding feminizing hormones. So that venous thromboembolic disease, that's a blood clot. So that's in bold, and that's a big one. We do also see an increased risk of gallstones, elevated liver enzymes, weight gain, and high triglycerides. So if your provider asks you for a lipid panel, that's a cholesterol panel. That's one of the reasons we want to take a look at those triglycerides. Also, in terms of the liver enzymes, we oftentimes will get that through a comprehensive metabolic panel that'll give us liver enzymes, kidney function, as well as electrolytes. I do like to just bring this up. Weight gain is actually on the list for both feminizing hormone therapy as well as masculizing hormone therapy. So I would just recommend being physically engaged and active as much as possible. There is an increased risk of cardiovascular disease, and we see that with high blood pressure and an increased risk of diabetes as listed on the table here. So if you have a family history of high blood pressure or diabetes, or you already have a diagnosis of either of those, that's a conversation. It does not mean that you shouldn't start HRT. It simply means that you should have a conversation about what that means for you. And there is a possible increased risk of the prolactin. So sometimes people can have some nipple drainage, and that's something definitely that I would encourage everyone to bring up to their prescribers as well. The good news is that there's no increased risk of breast cancer. I'm going to go over all those health maintenance things in just a moment, but that's something that we've not found to be true. So what happens if things change? You want to go slower, or you want to stop, or you want to go faster? How fast can we go when it comes to hormone, getting the feminizing therapy moving? I had mentioned the tincture of time. I still think that's a really important question and part of care that to consider. When a person starts HRT, how they look 6 months after starting therapy versus a year versus 5 years versus 10 years is very different. And so have that conversation with your prescriber. I just actually had an appointment today with someone who had said, they're really happy with where they're at in terms of their dosing now, but they probably are going to go down on their dosing because that continuum of expression is a little bit too extreme for them. And so that's okay. We talk about that and we figure out what makes most sense for them. And also, what do you do if you don't feel well on HRT? So I mentioned the nipple drainage. Definitely bring that up. That breast tenderness. It's not an unexpected finding, but bring that up and let that conversation happen so that you can hear from your provider. Oh, that's what I would anticipate. Let's talk about how to help minimize that. And this is because I can't help myself because of the primary care piece. These are all really important parts of your healthcare. So prostate health. When I look at someone, I say, what are those organs in your temple, in your body, that we need to continuously take into account? So that prostate is likely not going to do much under the influence of estrogen, but it's an important piece to consider. And a PSA blood test may be in your future. Bone density is something that you absolutely should have a conversation about. That's something that would be screened for in about your 6th decade of life, just to make sure that your bones stay healthy. Anyone who smokes for at least 30 years or has a 30-year PAC history, we look at screening for lung cancer starting at age 55. So again, keep that in mind. Breast cancer screening, for someone who is on feminizing therapy, we start mammography essentially at age 50, and that's as long as you've been on HRT for at least 2 years. Then it's really, really important to talk about your sexual health and well-being. PrEP, which is a whole topic unto itself, is something to talk to your prescribers about if that makes most sense for you. Also, how do you reduce STDs? Or the exposure or the risk. So make sure that you're having those conversations. Specific immunizations that I take into account are definitely hepatitis A and B, and then if you're eligible for the human papillomavirus vaccine as well. And then exercise and activity. It's not a silver bullet, but it can certainly help keep you healthy and well. Okay, so that's all I have here. I'm going to actually stop sharing my screen. There we go. All right.
And I'm going to pop back in. That was excellent. Thank you for a really concise package of information. So this is definitely a time for folks to ask questions. You can ask them in the chat feature. You can raise your hand, and Caleb, who is very smart and on our staff, will unmute you, and you can ask questions that way. So one person's asking, how much does this all cost?
That's such a good question. And the awful answer is I don't know. So it gets down to your insurance coverage. I would say in general, certain formulations are more readily covered than others. So sometimes people are unfortunately forced into, for example, the pills or the sublingual form over the injections because of their insurance coverage. But help us work with you on that so that we can document that, especially if you've had difficulty for whatever reason with one formulation, we may be able to do a prior authorization and get a different formulation covered.
Another question that came in is, do physicians always prescribe hormone blockers along with estrogen? Is there an age factor?
Great question. So not necessarily. Some of my patients actually choose not to be on Spiro, and that's okay. And so it really gets down to those goals. Generally speaking, the standard of care is to do both the estrogen and then the androgen blocker. But that doesn't mean that that's right for you. It doesn't have to happen that way. It just helps suppress that testosterone while increasing the estrogen component.
Perfect. I had a couple of questions that came in prior to your end. So let me ask them while people are still asking other questions in the chat. So one of them was about breast tenderness, and does it decrease over time? So if people stay at the same dose, does it decrease over time?
Yeah, it should decrease over time. So here's what I usually tell people about breast tenderness, and I want everyone just to hear me out on this one. It can be an inflammation process or just it's the growth. When people feel really sore, I recommend cold cabbage leaves. So cabbage actually has some anti-inflammatory processes. You put a head of cabbage in your refrigerator, grab a leaf, and apply that. So.
That is wild. I wonder if nobody has. I'm guessing that nobody on this call has ever heard that, so that's really cool. Let's go to a question in the chat, which is, where would you send a new nurse practitioner looking to prescribe HRT for the first time via informed consent? How do we start prescribing safely?
That's a good question. So literally I actually have my book holding up my computer. Fenway Health has a really great set of resources. I actually have a book from Fenway that when I started in the Inclusion Health Clinic, I read through that. The University of California, San Francisco, I cannot stress enough what a wonderful resource that is for all of us. And I like being on the same page as people coming in with questions, because it's like an independent resource. It's an encyclopedia. So UCSF would definitely be the other one. The charts that I shared are from WPATH. And so even though I'm not thrilled about the lens that they look at things, I like the resources that they provide there. So I would definitely, Fenway is excellent. Callan Lord also has some great resources as well.
And I know that Fenway also has like kind of a recurring educational series, so people can get more and more information in addition to that basic.
Yes, for sure. And our staff at the Inclusion Clinic, and I think a lot, it's a wonderful resource that they provide educational modules for people in different roles, I would say.
Mm-hmm. And they oftentimes do CEUs and stuff like that, so that's another bonus.
Yes.
So another question in the chat is, I know that there are gels similar to lotion forms of testosterone. Are there gel forms of estrogen?
Not at this point that I'm familiar with, or at least are readily covered. So that's a great question. Yeah. Mm-hmm.
And I know this is a long time ago, but I know that some of the compounding pharmacies used to do some applications of estrogens. But, yeah.
And there are estrogen creams, but those tend to be very focused for other reasons entirely. So, yeah.
Exactly. So there's a question about, is this being recorded and is it going to be available? Yes, it will be. It'll take me a little bit to edit it, but it will be available probably within the next week. So the other question that I had come in before, it relates to kind of where can I get more education, but it's a little bit different than that, which is that a lot of people are kind of put off when they hear WPATH or when they hear the word standards of care.
Yeah.
And, you know, what I heard, so I'm going to add to the question, what I heard you talking about, and those of us who are providers of care talk about, is it's a tool for us to use to kind of show where people might be or what some of those risk factors are. So if somebody came in and was like, oh my God, I can't deal with this whole standards of care thing, how do you navigate those waters?
Super great question. And I can completely appreciate that, the standard of care piece. At the end of the day, I want to know where your goals are. So how can I help you get there, or how can we get that journey moving in the right direction, essentially? So we know a couple of things about hormone replacement therapy, and that is that we want to introduce estrogen. So let's start there. Spiro, again, is not a perfect drug. Estrogen is not a perfect drug, but how do we help move that along? I think it's important too that for years, I'm not a big believer in the Wild West of let's just try anything. I know that, and I wasn't exactly sure how to bring this up as well. There is a physician in Michigan that has been on the internet and has a 2-hour, YouTube video about high levels, introducing high levels of estrogen. And we as a clinic have talked about that. And that really puts people in some significant risk groups in a bad place. So it's really important to just have that conversation with your prescriber. The other thing is that I'm one person, and if we're not getting the results that you're looking for, I'm absolutely going to send you to the endocrinologist, because sometimes having a second set of eyes on what those goals look like makes a lot of sense, or to the gynecologist or whatnot. So if you're not happy with where things are going, please keep having that conversation about that. So
that's cool. Thanks. So a couple more questions have come in. Can you speak more on fertility? Will trans women be able to produce their own eggs?
Great question. So at this point in time, I would say I don't know of any research that is looking at the production of eggs. I do know that there have been some studies coming out of the University of California, San Francisco about the response of sperm motility and production after stopping HRT for 4 weeks versus 8 weeks versus, a longer period of time. And that those numbers and that motility does improve and recover to a point. And so, so for someone who does want to have a biological child, that is still a possibility there. Once we get the hormones on board, there can be some effects that are not going to be easily reversible. So, but it looks like fertility is something that may have some response back, essentially.
Cool. So the next question is, what are recommended estrogen levels for trans women over 50 or over 60? My provider wants menopause levels and no estrogen after bottom surgery. How can you go through puberty when past menopause age, and how long can you stay on estrogen?
That's a great question.
Michael, I'm sorry to interrupt. Would you mind repeating that question for interpreting purposes, please? And
sure.
I'm sorry, thank you.
Yeah, no problem. So what are the recommended estrogen levels for trans women over 50 or 60? And then my provider wants menopause levels or no estrogen after bottom surgery. How can you go through puberty when past menopause age, and how long can you stay on estrogen?
So I actually, when I first began in the inclusion clinic, I was part of a conversation with a 65-year-old trans woman who started HRT that day. So what were those goals? Again, and she actually started on a patch. So that's going to, in some ways, be a more gentle approach. I think that it's important to say that there are fluctuating, in cisgender women, there are fluctuating estrogen levels. And again, I'm not an endocrinologist, so I apologize. But those fluctuate depending on cycles. And so this is one of the reasons why we look at that maintenance level of estrogen between 100 and 200. That will decrease certainly in that menopausal state. I think at that point, I would say, especially if your provider doesn't want you to be on estrogen after bottom surgery, truthfully, Spiro is not necessary for sure, because you don't have to block that testosterone. But I think it's important, if you're seeing physical changes that are not congruent with your goals, to reconsider even starting a small amount of estrogen. So that I don't have a specific goal to recommend, but I do know that some of my patients that are in their 6th decade of life will see thinning hair that they hadn't seen before, or changes to their skin. And so we start them back on patches, so at least they have some estrogen. In that situation, I defer to the endocrinologist for sure.
And aren't there changes with bone density, excuse me, if people are not on estrogen or testosterone or on any form of hormone?
For sure. So especially if someone has had an orchiectomy and they're not on anything, then we definitely need to be a lot more cognizant of bone health. And that would be done through a DEXA scan. And that can be done every couple of years. Definitely calcium is going to be a role in that, calcium and vitamin D. So, yeah.
Great. Cool. I know we have 3 minutes technically left. Are you, Annie, able to stay for a few more minutes after that? Because we have a few more questions. So, and so I'm going to have to spell this one out, and Annie, you can read it. Are there any circumstances where you would try Tamide?
Truthfully, I don't know what that is. So let me get back to you on that one. I'm gonna write it down.
Cool.
So,
next question. As far as we know, does HRT have any impact on one's risk of COVID-19 complications? I also had a question about that based on an article that I just read. But
ooh, yeah, Actually, do you, if you've got that, I would be curious to know what that article had to
I
say.
don't remember where it was from. It was a peer-reviewed article that was talking about, it wasn't talking about trans women, but it was talking about folks that are on estrogen, and there's an increased risk of blood clot changes for the folks that have COVID that have cardiovascular risk, or like cardiovascular symptoms related to COVID. And so there was like an increase in some clotting issues related to COVID with that.
That's interesting. And we're getting to know a lot more about COVID, that it's not a flu-like virus, that there are these inflammatory processes that are occurring that are causing blood clots. And so anyone who is at an increased risk of blood clots to begin with, I would say that there would be some concern there. In general, I've had patients who are on feminizing hormone therapy and have had COVID and they've been okay. That doesn't mean that that's the case for everyone. So I just want to put the plug in to make sure that you're wearing your masks and staying 6 feet away from people and washing your hands.
And if anybody needs masks, Forge has a whole bunch of them, and we are happy to send you one or a dozen or however many you'd like. So they're nice, they're different patterns. You know, we'd be happy to send you some if you'd like some. Can we do a couple more questions?
Yes, please. Absolutely.
All right. What anecdotal evidence have you seen for PMS symptoms?
Ooh. Good question. So I have some patients that have a lot of hot flashes, and what we typically do is treat them. And so oftentimes the first line of treatment is an SSRI or an SNRI, and that would be consistent with recommendations for hot flashes to begin with. And it would be like a low dose paroxetine or venlafaxine, something like that. So there are also over-the-counter recommendations. Black cohosh has been found to be somewhat effective in hot flashes as well. I would just encourage people to use their fans and layer their clothes like crazy. So.
And there's been some discussion in the chat about what that drug is that I don't remember how it's spelled or said. So it looks like it's it is a prostate cancer drug that blocks the receptors. So interesting stuff that we always get to learn new things.
Right.
So somebody's asking if you'd be willing to share your email or contact information, or I can send it, I can connect people privately, Annie, if you feel more.
Yeah, that sounds great.
Okay, cool. So I'm seeing a comment that says progesterone has increased mental health in some patients in addition to breast growth. And for some people it made them suicidal. So kind of that FYI about that.
Yeah, and I think that's an important point, that nothing comes without potential side effects. And so just understanding that it might be great for breast growth anecdotally, but we don't have great data so far. So we absolutely need more data on this medication. So I appreciate that mention.
That's great. It looks like there's one more question, and then we should probably wrap up. So the last question is, do providers in the inclusion clinic also act as primary care physicians?
Yes. So I am one of those. And then we also actually have someone starting in 2 weeks. So we have about 3 people that act as primary care physicians alongside prescribing HRT and PrEP as well.
Perfect. And I know we have some folks here today that are not
HRT and what, Annie? I'm sorry.
Oh, I'm sorry. And PrEP.
PrEP. Thank you.
Thank you.
And just the plug for PrEP, next week, Tuesday, Dr. Andy Petrol is going to talk about PrEP and sex and hooking up in the age of COVID. So we'll have many, many discussions about that in another week. Andy, do you have any last comments before we wrap up tonight?
No, I want to just thank everyone for attending. And really, at the end of the day, please, please find someone that provides healthcare that you trust. I think that's just so pivotal to everyone's well-being.
Yeah, it is. So thank you, Annie, for being here again. I know that you are bogged down with many different responsibilities in addition to work. So we really appreciate you taking the time tonight. And then in part 2 and part 3 down the road. So for those of you who came a little bit late, we're going to do this again. Annie's going to do this again for masculinizing hormones. And then a month later for how hormones can affirm and enhance non-binary folks and identity and expression. So those are some of the things that are coming up. Andy Petrol is going to talk next week about PrEP. We'll have a couple of writing workshops in the next couple of weeks, next month. And we're going to talk about depression on September 15th. So there are things that are coming up. There are more and more recorded videos. So this is recorded now, and we'll have that available for folks to check out as well. Again, if you want masks, let us know, and we will be happy to send you one. And I just wanted to thank everybody for being here. And if you will take a moment after we close out to fill out a very quick evaluation, we'd really like to hear your feedback on it. So thank you, Annie, and thank you for everybody else who's here tonight, and thank you to the interpreters that always do a fantastic job. So have a good night, everybody. Thank you.
Thank you.